Hi, my name is Christine Hodgson. I'm a metastatic breast cancer patient and advocate, and I'm here today with Dr. Peter Fecci, and I'm very excited to talk with him today about his work on brain metastasis. Dr. Fecci is a neurosurgeon and director of the Center for Brain and Spine Metastasis at Duke University. He performs surgeries to treat brain tumors, including the emerging technique called LITT, or laser interstitial thermal therapy. He is also a cancer researcher and serves as a director of the Brain Tumor Immunotherapy Program, also at Duke. Thank you so much, Dr. Fecci, for joining us today.
Thanks for having me. I appreciate it.
I want you to we'll take a step back. We said that you're a neurosurgeon. Can you tell us what is a neurosurgeon and what role do they play in the treatment of cancer?
Sure. In general, neurosurgeons are those that operate on either the brain or the spine. And that can include, pathologies that range from things like a herniated disc all the way up to brain tumors, spine tumors, aneurysms, et cetera. And we tend to all specialize quite a bit. From my perspective, I'm specifically a brain tumor surgeon. I have colleagues that operate on metastases or other tumors within the spine, but I focus specifically on either primary brain tumors, which are tumors that arise in the brain, things like glioblastoma, meningiomas, et cetera, or brain metastases. So cancers that have traveled to the brain from commonly places like the lung, the breast, or the liver. And of course, breast cancer being the topic of conversation here, that tends to be the second most common cancer that travels to the brain.
Yes, and what kind of surgeries do you perform on breast cancer patients, specifically with brain metastasis?
Sure. So in certain instances, those tumors can actually be removed, or we use the word resected from the brain. And when we look at a patient, basically what we're trying to decide is a tumor that they have in their brain more amenable to just radiation up front, or is it a tumor that should actually be removed prior to radiation? And the reasons we might consider one versus the other have to do with things like location in the brain. Is it safe to operate, for instance? How large is the tumor? If it's particularly small, maybe less than 1.5 centimeters or a centimeter, it's not frequent that we would go in there surgically. Often we would just reserve something like that for radiation because it might be very effective against such a small lesion. If tumors are larger, maybe larger than 2 or 3 centimeters, they're in an area of the brain that we can go safely, and they're causing a lot of symptoms in particular, then it's often beneficial to take them out. Number one, to relieve the symptoms that the patient might be experiencing, and also to make subsequent radiation therapy work better, because that radiation tends to work better when a lot of that mass has been removed. In general, however, if someone has a lot of tumors, taking out one isn't going to make a big difference. So oftentimes people that have either not very many tumors in the brain, or maybe have one larger lesion than the remainder, and that large lesion is causing symptoms, those are the instances when we're more likely to consider surgery prior to radiation.
Got it. And we are actually going to interview some experts in the field of radiation oncology as well. So we'll definitely be answering questions that folks may have about that type of treatment. And you did mention, so what I'm hearing is that it really is going to depend, which we hear this a lot as a metastatic breast cancer patient. I hear all the time, we don't really know exactly because every person is so unique. So what I'm hearing is that surgery is really going to depend on the size of the tumor, the location of the tumor, and whether it's causing symptoms.